everyone, and welcome to another vlog. I'm Diane, menopause counsellor and founder of Menopause Support and the Menopause Support Network. And today I am delighted to be joined by Dr Nighat Arif. And Nighat and I are radio sisters.
We are
That's how we first met. We actually connected. She actually wasn't in the studio. We connected on the radio, and then I got to meet her a few months ago when I did a talk in Dunstable, and this lovely woman came along with one of her colleagues. So I really wanted to talk to her today about all things menopause and also some of the cultural challenges around that. So, lovely woman, thank you for coming and giving up your time.
Oh, thank you for having me.
You're very welcome.
I'm genuinely shocked we made time to do this, Di. This is amazing.
Right, lovely. So, could you introduce yourself to everybody and tell them who you are, where you come from and what you do?
So, I'm Dr Nighat Arif. I'm a GP in Buckinghamshire with a specialist interest in women's health, and particularly over the last couple of years I've become very interested in the menopause and how that is viewed amongst the ethnic minorities that I work with in Buckinghamshire.
Okay, so talking of ethnic minorities, lovely, you and I have been talking a little bit about your heritage. Could you tell everybody a little bit about your heritage?
So I'm Pakistani from Punjab, and therefore I speak Punjabi and Urdu as well. And I work mostly with women from a background of South Asian background. So that's Pakistani, Indian, women from Nepal, Bangladeshi women, and we have a few African-Caribbean women that I deal with as well.
Okay, so you and I have spoken quite a lot about the menopause and about the challenges of menopause generally, and about the lack of formal GP education, about the lack of education for women, which kind of leads to this sort of chasm where there isn't knowledge, which can be difficult. So I had got really interested in the fact that, you know, that I run the campaign, and I think we should make menopause matter for every woman.
Yeah.
But I was really interested when you and I met and we got chatting about some of the challenges that you see in your clinic, and more importantly, those women that you're not getting to see.
Yeah.
So could you talk a little bit about what those challenges are, both the ones that you see and the ones that don't even get to your clinic?
If I can just go back a little bit.
Yeah.
Even not in my clinic, in my community.
Yeah.
I've grown up with Pakistani ladies all my life. We are entrenched in practices at the mosque. I go to their weddings, I go to their funerals, I go to their homes when a baby is born. So this is things that I deal with day in, day out.
Yeah.
And Pakistani women across the board, if I can make a generalisation, actually view women's health with a bit of embarrassment.
Okay.
And they find it very difficult to talk about heavy periods, painful periods, just starting at that. Even pregnancy, they will hide that.
Okay.
We live in a community which is quite insular.
Right.
So mostly girls are expected to get married at a particular time, so maybe 17, 18. If you're on the shelf by the time you're 25, that's too late.
Okay.
We still practice that. And therefore you're expected to go and live with your in-laws.
Okay.
And that is a practice that's happening across the UK. So we might have left from our South Asia background, but the practices are still the same.
But the cultural practice still carries on.
Still the same. So the woman will be living with her father-in-law and her mother-in-law. So she's expected to hide her pregnancy, hide her heavy periods if she's experiencing that.
Okay.
God forbid if she suffers from endometriosis and painful periods, she'll hide that. So that thought process goes throughout life until the woman becomes to perimenopause and menopause.
Right.
Perimenopause happens around the age of 40. We know that. The fluctuations of the hormones happen. But as an Asian community, we don't recognise it. Firstly, there's no word for it, so that's number one, the challenge.
At all?
Well, in Punjabi, it's known as no kapde, which basically means no cloth, because it comes from the British term as being on the rag. There's a layman's term in almost, I would say, derogatory term, just saying that the woman isn't on the rag anymore, which is awful.
So she can no longer bear children.
Exactly.
Okay.
And in Urdu, the menopausal word is banji. Banji means she can't have children.
Right.
Which is not the menopause either.
No, absolutely.
Why should a woman be defined on the fact that whether she can bear children or not bear children? But unfortunately, that is how our cultural practices are.
Yeah.
And therefore, when you don't have a word for it, women don't recognise it.
Mm-hmm.
My own mum said to me one day, the menopause only happens to white women. And I'm sorry about that.
Really?
But that's embedded in all her community. I spoke to all her friends, and they said exactly the same thing. They said to me, this is something that only happens to white women. And my jaw hit the floor, and I looked at my mother and I said, you do realise I'm a GP and this is something that I talk about a lot. And she said, yeah, I know, but it's almost become a make-believe. So when you don't have a word for it, the condition is a make-believe.
Right.
The woman doesn't have knowledge of it.
Yeah.
She has no knowledge of the complications that come about with menopause. So osteoporosis, heart disease, dementia, the new research is coming through, risk of diabetes. She has no, so there's almost this void of knowledge regarding to the fact there's actually treatment for the symptoms that you're experiencing.
It's so interesting because you talk about that void of knowledge for that community, but of course that void of knowledge is actually, it's compounded within your community.
It is.
But it's actually for everybody because we don't get any kind of education about menopause. So you speak to women from all different cultural backgrounds. I speak to women from, kind of everywhere. And they say, I wish I'd known that. I didn't know. I didn't know that perimenopause could start in the early 40s. I didn't know that I could have HRT if I was still having bleeds. I didn't know that it was anxiety, low mood, what I might call depression, etc., etc. So it's almost as if the women that you're talking about they actually have sort of even more barriers to cross.
But the knowledge that you're talking about comes from mother to daughter or grandparents or aunts. But when you are told to hide those conversations because it's embarrassing, and in our culture, talking about women's health is associated with sex. Sex is associated with promiscuity. And if you're seen as a promiscuous, God forbid, Muslim, Pakistani woman, that is the most shameful thing.
Okay.
Because women are meant to be pious individuals who are just all things wonderful. Everything about the woman can't go wrong. And she is, do I say it in a horrible way, but she is still seen as her shame and her izzat, which is a word that we use. I can't find the English word for it actually. Is all imbounded on her ability to keep her virginity and her sexuality safe and quiet. And it's almost, she has to keep it under a cloth. So a barda is what we use in our language. It has to be under a barda. And when you start having that concept, the mother can't pass that knowledge on to the daughter. Right. And that happens with every single generation.
But what I'm saying is that information isn't being passed on anywhere.
It isn't being, well, I think it's more so within your communities, though. It is. It is starting to because of your work.
It is starting,
but women have always had
huge. There's still a massive gap.
But in the 60s, there was this sexual revolution. If I can go back that far, and women were openly discussing, using tampons and pads and
using the pill.
Using the pill. The pill became, and it wasn't seen as if a woman had sex, it wasn't seen as the worst thing ever. In my community, it's still such a shameful topic.
I think what I'm talking about is menopause specifically, lovely. But kind of the big gap in menopause, because so many women over the decades have not been able to recognise their menopause symptoms because nobody explained to them what those symptoms are. I think actually it's only now, sort of from an educational point of view, that we're starting to be able to say this is what it is. But I do see what you mean from the wider perspective.
From the wider
Absolutely.
perspective, because also in our community, women's fertility is so involved.
Right.
So the menopause means no fertility, and therefore that's a shrouded subject yet again. You can't go through that. And to a degree, I think in the Western culture, menopause is very much linked to eternal youth. And to be able to talk about the menopause, it's almost like, well, I'm not young anymore. And that was where women had the barrier. If in an office, a woman who was probably at the best job, she's at the top of her CEO of the company, if she has, God forbid, a hot flush, it means that she's past it. And that made women's self-esteem come into question. And therefore women found it really hard to talk about it. Conversely, if you flip that round, doctors aren't picking it up.
No.
So as a GP, imagine having all those barriers in the community. Language, unable to pass on information because everything is shameful. and then you're having hot flushes, which only, by the way, 10% of women have. You're having aches and pains, which is usually how women present, because in our community, women...
Really? Only 10% of women
have
hot flushes?
It's a small statistic. Not every woman gets hot flushes.
I thought it was 20% of women didn't have hot flushes.
Oh.
I thought it was 80% of women did have hot flushes, 20% of women didn't. We need to check that.
We need to check.
And put a note underneath. It's fine.
It's fine. I'm really sorry. I need to check that. No, but not every woman does. I think that's the...
No, not every woman does.
That's the most important thing. Not every woman will get a hot flush. Not every woman will have night sweats. Not every woman will have the symptoms, classical symptoms of the menopause. No. Some women just get memory fog.
Yep.
Some women will just come in and say, look, I've lost this self-esteem. I'm a 45-year-old woman. I'm a barrister at the top of my career, and suddenly I feel absolutely anxious about doing the most simplest thing.
Yeah.
And we can't put your finger on it. And all the blood tests, everything is completely normal. So surely that's where, as a doctor, you need to be thinking outside of the wider scope and have menopause as a differential. We don't have that.
But you can only have it if you've been educated about it.
Yes.
And as we've said before, you only know what you know.
So true.
And if nobody's taught you, and of course we go back to the fact that every woman will experience a menopause. We know for all of them it's not going to be debilitating, thankfully, but every woman will experience it. So consequently, every GP needs to at least have the basic knowledge to be able to pick it up.
And that is slowly, because of your amazing campaign, that is happening. And you're getting doctors like myself who are saying, hang on, we need to involve every single woman and actually look at it within the cultural practices as well. Yeah. So Pakistani women, they have the language barrier, and then you don't get translators on the NHS.
It's not fair to say that all Pakistani women have the language barrier, though, is it? Would it be fair to say probably some of the older generation who maybe have
mostly what I'm seeing, it's within the older generation that do have that language barrier, but also in the younger generation, they're thirsty for this knowledge. They really want to know about the menopause, and women in their sort of 30s are starting to become more and more educated about it. Mm-hmm. But when you go and see the doctor then and say to them, well, I'm having all these symptoms, doctor. Yeah. Do you see where the dichotomy happens? Where you just can't...
Absolutely.
There's a barrier and you can't go
honestly,
forward.
Lovely, every single day of my life, I speak to women who say to me, I've got these symptoms and my doctor's not picking it up.
Still in my own culture, the doctor is meant to be the all-knowing, the wonderful. You don't question the doctor. The doctor has to be knowledgeable about everything. And I will see women in their 60s and 70s, even now when I see them, and I'll say, Auntie G, is there anything else that you want to ask me? She'll say, no, dear. What you said can't be wrong.
Okay.
So it's almost like the responsibility always lies at the feet of the doctor. Yeah. But in Western medicine, as GPs, we taught that it has to be a conversation. Mm. And as a community, we need to be empowering our community to say, you need to have that conversation. Do not leave it that the doctor will be all powerful and all knowledgeable.
And again, I think, sort of you're talking about an exacerbated situation, but actually there are still a lot of people of whatever culture who think the doctor must know best, because that's the way that they've been taught. And I know that I've spoken to you a lot. I know that you do kind of the talking. I know that it's a two-way situation, but actually it's not like that with all your colleagues, I'm afraid to say. And you probably don't want to say that, but it's true. It isn't like that with all your colleagues. And that's a teaching. That needs to be something that how to talk to somebody is something that needs to be part of training. Because what so many women want is actually, they want somebody to listen. They want somebody just to listen to what's going on. And of course, the massive advantage, because I know that you're all-time poor and that you've got too many patients and not enough time, is that actually, if that happened more often, there wouldn't be 4, 5, 6, 7, 8 appointments for a series of what seem like not connected symptoms, which are actually all related to perimenopause.
But that's a system fault, and I know that on a bigger level, the Royal College of GPs are looking at that, because as an NHS GP, the 10-minute, I don't know where that came from, but it's rubbish, if I can say that.
It must be impossible.
And I can tell you, hand on heart, I do not do 10-minute consultations. I just can't work that. Yes, that means I overrun, and yes, that isn't great as a clinician, but that's the offset that we have to have, and a lot of my colleagues are feeling that pressure.
Yeah.
Because to get a valued consultation, and if you need a translator in that consultation, it's going to be a longer consultation.
How available is that service?
So at the minute, at my practice, to get a translator, you're looking at a 3 to 4 week wait.
Really?
So if you've got a woman who's, say for example, suffering the symptoms, palpitations, for example, so she's getting up and she's getting terrible palpitations at 3 o'clock in the morning, and she thinks, right, this is my 4th night, I've not slept, and this is all due to the menopause, I need to see the doctor, but the language is the barrier. She'll will possibly rely on her husband to translate, who might or might not understand.
Yeah.
And
would she feel comfortable necessarily if she's struggling with vaginal symptoms, urinary? Would that,
those are really difficult. How do you take your child in with you into the consultation, and even if they're in their 20s, to talk about that?
Yeah. So
I see women in there who's 66 who suffer from vaginal dryness, and they've had to bring their son in to talk about it.
Yeah.
And then the relief that they feel when I say to them, I can speak Punjabi, let's have this conversation, and their son leaves. And that's the other thing. I'm not saying that all doctors need to be bilingual. But if you can, what I really would desperately like is doctors within who have a women's health interest to use their language skills and actually call out to the women in their community. So they will come and see me because they know that I can speak the language. Yeah. And that's where...
So that needs to be made known within each practice, doesn't it?
And it's not always made known. That's the... Okay. Because they won't say, oh, this doctor can speak this language unless the patient specifically asks. Yeah. And we should actually, I think, be writing up on a board or...
Well, it's a service, isn't it?
It's a service saying this doctor can speak this many languages. Yeah. I don't think I've ever gone into a surgery, actually, that says...
No, I don't think... I've certainly never seen it in my practice, and my practice is quite big.
And it's almost seen as that the best way to consult is in the English language. The best way to do things, it has to be Western medicine. Actually, we should be stepping out of that box and not just sticking to guidelines all the time, but listen to the woman, which is what you said. Yeah. Hear her.
Or the man.
Yeah, or the man.
Whoever it is, and it's about being heard, isn't it?
Consult in the dialect, that's really important. So I've actually had colleagues who've done A&E, and they've said that they've spoken in Punjabi, and a nurse or a ward staff will walk past and say, "Can you speak in English, doctor?" And
really,
so,
even though it's actually
part of the consultation,
but more productive.
So I've had backlash from other colleagues saying their experiences. So there's almost this belief that you can only consult in English.
Right.
And I really believe that you should always put the patient at the centre of your care.
It's got to be, hasn't it?
If you put the patient, man or woman, child, at the centre of your care, the rest of the stuff just falls into place. Yes. And that's what we're missing in general practice, unfortunately.
Yeah. It's got to be what works for the patient, hasn't it? Absolutely.
Of course.
So I'm just actually thinking about what you just said, 3 to 4 weeks. I mean, going completely away from menopause, if that's somebody who is perhaps going to be diagnosed with something not to kind of underplay menopause, but something much more significant, that 3 or 4 weeks could be vital.
Yeah, it could be vital, and that's where you come back to using relatives. Right. Or you'll try and find a colleague in your practice that can translate, so maybe a nurse or a health visitor. Yeah. And if you are stuck, you can get a translator to come in as an emergency, but the costs
is huge.
Okay. I can't think of a number on the top of my head, but I do remember a colleague of mine said that they had to almost pay £300 for a 10-minute consultation to get a translator in.
Oh my goodness.
Because they needed to give this news to the patient that needed to be translated to her.
And from the point of view of the practice, that's a huge cost, isn't it?
Yeah, because they're small businesses.
Of course.
So
I think lots of people don't realise that GP practices are small businesses.
That's where the problem lies.
We're going to talk about that, aren't we? We're going to do another one of these.
We can talk all day.
We're going to do another one of these in a little while, which we will also put up, which is about Nighat's experience of training as a GP, what GP training is like, what we think needs to change, and then about her experience of working within a small practice, so you can get a bit more of an idea about it. So lovely. Could you give an example? Obviously, keeping all names anonymous, but could you give an example of what you've just described with a female patient coming into your practice who perhaps has been struggling for a long time and didn't realise what was going on for her?
Actually, I can use a really a simple example that I saw only a couple of days ago. And this patient won't mind me sharing because I'll keep all the information.
Yeah.
But a 66-year-old lady came in, and she actually came in with her daughter-in-law who was 6 months pregnant, and the daughter-in-law had been having some urinary symptoms. So she came in with her daughter-in-law, and when they realised I could speak Punjabi, they were new, the daughter-in-law just sat there quietly, and she said, "Can you speak to my mother-in-law?" So I spoke to her, and she was describing barn door examples of vaginal atrophy.
Right.
She was having recurrent UTIs, itching at night time, and the other massive taboo thing, which I did ask her, is sexual intercourse.
Yeah.
Her face just dropped, and this shame came over her because there's this concept that women don't talk about sex or don't stop having sex after the age of 40 in our culture.
Okay.
And she actually laughed and said to me, "Assi ye gal nahi karde." That means we don't talk about this.
Okay.
And so I
even with our doctor?
Even with a doctor. But I refuse to be embarrassed for her, because
Yeah.
if you become embarrassed as a doctor,
Yeah.
then you can't go anywhere. So
Absolutely.
I said to her, "Is sharam di gal nahi hai." So I said to her, "This is not a shameful thing.
Yeah.
We will talk about it." And just giving her the ability to talk about it and telling her it's okay,
Yeah.
made her open up about all her symptoms. I looked through back her notes, and she'd had 8 visits where she'd been having antibiotics, clear urine samples, and she said to me, "I've actually had all these symptoms with difficulty with sex." She had been having night flushes, night sweats, hot flushes. She'd had palpitations. She'd had thinning of her hair that started at the age of 40.
Oh my goodness.
And she said to me, "I thought it was acceptable."
Oh, bless
And
her
no one had
heart.
told me about this, one. And secondly, when she came to the doctor, her aches and pains were put down to fibromyalgia. Her anxiety was
that
put
all
down
the
to
time.
depression. And all her symptoms started when she was trying to get rishtas, which is marriage proposals for her children, because that's a common practice.
Oh, okay. So this is going to happen at about the same time as perimenopause?
Exactly. So women in our community don't recognise it, because they'll often say to me, "Oh, it's because of the stress I'm under. I'm trying to look for a rishta for my daughter, which are really hard to come by." And I'm like, "Okay, Auntie." And it's always blamed on something else, but
Right.
they don't realise that this is a physical thing, because there isn't a physical test that you can do.
Yeah.
It's not like they associate it. Well, with diabetes, you can see my sugars going up and
Yeah.
down. If it's cancer, you can see all the tests.
Yeah.
There's no test for it. So it's almost like this myth, this make-believe condition. And this poor woman, I said to her, "This is treatable. We can actually treat this with localised estrogen." And the shock and the relief on her face was the fact that she wasn't going mad. So this is cross-cultural, this is
Bless her
cross-ethnicities,
heart.
cross-languages. And took out Jane's leaflet.
Yay! So for anybody that doesn't know, our friend Jane Lewis has written a book called Me and My Menopausal Vagina, which is a fantastic read.
Brilliant.
But also she now has a leaflet which is in English and in Urdu, is that right?
Yeah, which I translated.
Yeah.
So I gave that to her, and it was almost like the light had come on, and she suddenly realised, this is the condition I've been suffering for the past 10 years, and no one had told me about it. But the sad thing was that she used the opportunity at her daughter-in-law's antenatal clinic.
Yep.
She still wouldn't have had the confidence to
come on her own.
Yeah.
To ask for that.
Yeah. So that's where I'm actually picking up ladies.
Right.
That will come, especially older ladies, because you're already talking about pregnancy, you're already talking about gynecological things.
Yep.
And it almost gives them that break-in, that doorway, that opportunity to talk about something else. And that's where I pick it up as a GP.
Okay.
But only because I know about it, and you only know what you know.
Absolutely lovely.
If I was another GP that day who probably just said, yeah, I think it's a UTI, looking at your notes, just drop a urine sample off at reception.
It'd have been another 3 days of antibiotics.
Exactly.
Oh my goodness. Okay, lovely. So I never like to talk about challenges without talking about what the answers to those challenges might be.
Yeah.
So, you know, as I say, you and I have spoken about this at some length in the past. But I would like to know from a wider perspective and also from the narrower cultural perspective, what you think the simple answers to some of this might be. And some of them might not be simple, some of them might be more complex.
So the most simple answer, listen. As doctors, please listen. I mean, that is the core of medical care. And if everybody does it, actually that would be the basis of it. And the other thing is, as patients, as women, and particularly when it comes to menopause, become empowered by it. And that's across cultures. So try and speak to people who can advocate that health in your community in that language, which is what I'm trying to do in Cheshire and in Buckinghamshire as a whole. And there are people on the ground in your community, women who are, as like me, proactive about it. Do not be shamed by anything. As a woman, please never feel that sex isn't something you can't talk about, vaginal dryness isn't something you can talk about, urine infections, you can't talk about that, because mental health you can't talk about. Nothing is off the table. And as communities, we need to be able to talk about anything and everything. Yeah. And then lastly, if I can make a call to all my colleagues, please look at women's health and see what changes can be made within your practice. And it comes down to education, I think.
Because I'm right, aren't I, that 1 in 4 consultations is going to be about women's health?
Yeah.
And when I think about it from the point of view of not just the woman and her well-being, but also, you know, I will be very honest and say that I have counselled doctors who are under severe amounts of stress because of, you know, kind of time limits, because of pressures within the practice. I know of several who have gone part-time because of those pressures. Actually, if we got our ducks in a row and we had the right education, and we had more education for women, certainly, and I think the same applies in many areas of men's health too. And if we had that, you know, sort of that communication between doctor and patient, then we would actually reduce doctor consultation time. That word nearly didn't come out.
But we would reduce repeated consultations for the same problem.
Exactly. Or for what seem like problems that aren't linked, but actually are, because they're all perimenopause. So you, as I say, you wouldn't have repeated appointments. You also would save the NHS money, because you wouldn't be sending patients off for cardiology for palpitations, for rheumatology for their achy joints, for the one that worries me the most is psychiatry, you know, for low mood, anxiety, etc. Which, you know, sort of, I have to say, I've had several clients who have been in that situation, and it is so distressing. So I think the thing is, you're right, it does come absolutely down to education, doesn't it?
And I think that, coming back to saving money, as a GP, you can actually save costs in your practice, if we come back to the fact that a practice is a small business. Because if you know that the woman hasn't had a period over a year, she's menopause or postmenopausal, you don't need to do blood tests.
No.
The amount of women that will say to me, I've had a blood test, I've not had any periods for a year. Actually, you could have saved that money from female hormone testing.
Well, and nice guidelines are clear, aren't they?
Exactly, and the nice guidance are clear. So it always comes back to education, as most things. But within my own community, we need to be tackling these taboo subjects within the community, using the language that we know, because that is the only way that change will come.
Yeah, absolutely. Thank you for that, my lovely. Before we round up, is there anything else pertinent to this that you would like to share with everybody? Or would you maybe like to share a few lines in a different language that might be helpful?
Yeah, I would love to, if I can speak in Punjabi for a little bit, if there are any Punjabi listeners. So मैं एक डॉक्टर हूँ, मैं आखता वुमेन्स हेल्थ करती हैं और मेनोपॉज एक बीमारी है जो शुरू हो जाती है एटलीस्ट आखता 40 साल की उम्र च ये बहुत वगैरह वगैरह आखता कि रास्ते होंगे जो नज़र आते हैं मेनली अगर तुहानू आखता कि पसीना रात को आता है अगर तुहाडे जोड़ दुखते अगर दिमागी तौर पर तुहानू फील होंदा जो मैनू चीज़ां याद भुल जांदियां ते नाल तुहाडे अगर आखता कि पीरियड हो सकता कदी कदी आ जान कदी कदी चले जान जब बिल्कुल खत्म हो जान प्लीज़ अपने डॉक्टर नाल गल करना इसलिए मेनोपॉज हो सकता है तो गल ये जो ये इलाज हैगा एक दवाई है HRT ਉਹਦੇ ਨਾਲ ਤੁਸੀਂ ਇਲਾਜ ਵੀ ਕਰਾ ਸਕਦੇ ਤੇ ਉਹਦੇ ਨਾਲ ਤੁਹਾਡੀ ਹੱਡੀਆਂ ਜਿਹੜੇ ਜੋੜ ਹੈ ਇਹ ਆਗਤਾ ਬਚ ਜਾਣਗੇ ਤੇ ਤੁਹਾਡੇ ਦਿਲ ਦੀ ਹੈਲਥ ਔਰ ਹੋ ਸਕਦਾ ਹੈ ਕਿ ਤੁਹਾਨੂੰ ਹੋਰ ਵੀ ਬਿਮਾਰੀਆਂ ਤੋਂ ਬਚਾ ਦੇ ਅਗਰ ਤੁਸੀਂ ਆਗਤਾ ਕਿ ਆਪਣੇ ਡਾਕਟਰ ਨਾਲ ਗੱਲ ਕਰੋ ਤੇ ਇਹ ਅਗਰ ਦਵਾਈ ਸਹੀ ਹੈ ਤੇ ਇਹਦੇ ਨਾਲ ਤੁਸੀਂ ਠੀਕ ਹੋ ਸਕਦੇ ਹੋ ਲੇਕਿਨ ਜ਼ਰੂਰੀ ਨਹੀਂ ਹੈ ਤੁਸੀਂ ਘਰ ਬੈਠ ਕੇ ਆਗਤਾ ਇਹਦੇ ਨਾਲ ਸਫਰ ਕਰੋ ਇਹਦੇ ਬਹੁਤ ਬਹੁਤ ਇਲਾਜ ਹੈਗੇ that's it.
So lovely, because I am not nearly as talented as you and do not speak Urdu. What did you say?
So I just gave a brief blurb of what the menopause is and the symptoms around it and the fact that there is a treatment called HRT and that women can discuss with their doctor to see if it's amenable to them, but please don't suffer in silence.
Excellent. That's a brilliant message to end with for everybody. Please don't suffer in silence. So my lovely, could you just tell everybody again where you practice?
So I practice over 2 practices. As an NHS GP, I practice at Rectory Meadow in Old Amersham, and as a private GP, I work at Dr Nighat in Beaconsfield. And I'm all over social media, so I'm more than happy.
She really is.
I really am, because I'm trying to change
where can they find you on social media?
You can contact me on Twitter at Dr Nighat Arif or my Instagram, which is the same handle at Dr Nighat Arif.
Fabulous. Thank you, my darling. So, lovely people, for those of you that are not aware, I mentioned earlier the Make Menopause Matter campaign, and I'd ask you to translate that, but you told me that there really isn't a word, didn't you?
I just don't like using those words.
So that would be no. So it's the Make Menopause Matter campaign for everybody. We've got around... I think we've got about 90,000 signatures on the petition now, which is amazing. So the petition calls for 3 things. It's for mandatory training, for mandatory menopause training for all GPs. It's for menopause awareness in every workplace, and it was to have menopause included in the new RSE curriculum in secondary education, and I'm delighted to say that we actually achieved that in July. So that will happen from September 2020. If you would like to contact me, it's menopausesupport.co.uk. If you'd like to join the private Facebook community, it's the Menopause Support Network. And you can find me, my name's Diane Danzibrink, there aren't many of us. You can find me on Twitter. You'll find this and other videos like it on YouTube, and you'll find me under my name on Instagram. So again, thank you so much. And we will be back with another one of these. I will see you soon.